experience in conduction system pacing in patients with congenital heart disease. Unlike people without congenital heart disease, there is consideration of the anatomy as far as the heart function and the treatment of heart function point of view. This group of patients, perhaps we can divide them into three categories. The first is very similar to patient without congenital heart disease, which is a patient with systemic left ventricle, where the left ventricle is responsible for the circulation of for the rest of the organs, as opposed to systemic RV function, where the main pumping chamber for the organs outside the lung is from the right ventricle. Of course, in the extreme end of the spectrum is the single ventricular physiology, which serves both sides. Now, similar to patients without congenital heart disease, single ventricular pacing is found to be detrimental in heart function. This is the work we have published 10 years ago, showing that patient with a systemic RV function, when you pace the single ventricle, in this occasion left ventricle, we have seen a deterioration of function, size, and also the valve dividing the atrium and ventricle on the systemic side. Therefore, as patient without congenital heart disease, we in this area one have investigated the role of conduction system pacing. We are very early in the journey in this cohort. If you look at where we are in 2024, we are at the infancy in this technique, mainly the retrospective series of feasibility in this population. We're not there understand the physiologic effects, and we certainly don't really have any long-term outcome, let alone and perhaps also intermediate-term outcome. Randomized control trial in this population is an aspiration rather than reality, mainly because of the numbers of this patient population is rather small. So I would like to share with you our experience in this population. Dr. Wang has invented this technique, which we follow around the world and spreads to all corners like a wildfire, including patients in this population. And we have tried this technique in 13 patients, which we have published last year, and different type of anatomy. Compare them with the patient without congenital heart disease, looking at the feasibility really, and we have found that it is feasible. We can do it in this population. So the blue is congenital heart disease, the orange is without congenital heart disease. If you can see, look, we have been quite conservative here, and the 13 patients we have performed, the mean QRS duration is 150, compared with more liberal approach in patients without congenital heart disease, about 118. We're able to reduce the QRS complexes significantly in this group to 135 milliseconds. And this pacing spike to R wave, peak R wave in V6 was respectable, 66 in this population versus 67 in patient without congenital heart disease. And the pacing parameters were very reasonable and this group of patients. So testing for feasibility in left bundle area pacing in patients with congenital heart disease. I'm not going to talk about his bundle pacing, which is more a procedure that is performed less around the world. Now, in terms of cases, I would like to share with you maybe a couple of cases showing some of the challenges we face in this population. First of all, even with simple anatomy, patient with corrected fellow tetralogy and may not be that simple. Very often the chambers are dilated and we have to modify our tools a little bit, the sheath, to get us to the place we want to get to, change the curve, for example, or use an auxiliary sheath to help to guide that the pacing, the left bundle area, and the results can be reasonable, yes, and PQRS duration during pacing left bundle areas under 34 milliseconds. Now, we have to understand left bundle pacing may not be the answer for all patients in this condition. For example, in fellow tetralogy, there are other reasons why QRS duration is prolonged, not only the left bundle pacing area that pacing can correct, perhaps it may be related to right side of the heart as well. Second patient is, I've been asked to be involved, a patient with congenital corrected transposition straight artery and has an corrected operation, double switch operation, his infancy, and with complete heart block, initially treated by epicardial pacing, surgical procedure, followed by intravenous, transvenous system at the age of 4, with a number of generator change, and come to a point where the physicians looking at the patients was thinking about upgrading the pacemaker to a dual chamber pacemaker and asked me whether the conduction system pacing is feasible. Now here is the anatomy for those who's not very familiar with this type of patient. First of all, the congenital corrected transposition is double discordance, meaning that the atrium, the right atrium, is connected to the left ventricle, then to the pulmonary artery. On the other side is the left atrium to the right ventricle to the aorta. And the double switch operations on the left-hand side over here, my left, your right, is that the right atrium has been redirected to the left ventricle and then to the aorta, and whereas the the right ventricle is the right atrium to right ventricle to the pulmonary artery, and the left atrium to the left ventricle to the aorta. So it's a little bit confusing when you come to try to place the left bundle area leads. You may be imagined, but it is feasible. Now, I'm not sure I have a mouse. Yes, I do. Okay, so the best way to look at this heart is maybe on the lateral view, and the thicker lead is the original pacing lead for many years, and the new lead is the right atrial lead over here, and the left bundle area pacing lead is to the posterior chamber, which is the right ventricle, and coming back to pace the septum anteriorly. So the tools to achieve this need to be modified, but the result is not bad at all. And this is the complete heart block intrinsic QRS complexes. And here is the original RV pacing QRS complexes, which is from this lead, the thicker lead. And this is the left bundle area pacing lead that we have placed with QRS duration 120 milliseconds during pacing. Now, as how do we, and the end result is also pretty encouraging. There are very desynchronous left ventricular contraction during a pacing of the apex, and if you look at the synchronicity during left bundle area pacing has significantly improved, so did the heart function and patient symptom. So how do we achieve that? How do we achieve this type of pacing? So the tools actually is designed to pace from this side of the septum. We want to pace this left bundle area from the other side of the septum. Perhaps the tools ought to be modified in a way that to completely reverse the secondary curve to the other direction. And we thought about how to do it, and and we choose to use the C315 lead, which is more malleable, is able to change the shape easier than the other sheet. And so this is what the scheme we come up with, and so completely reverse the primary curve to achieve the opposite direction into the point in the secondary curve. So reversing the direction of the sheet. So the third anatomy here is a single ventricular physiology. This is completely uncharted territory. I certainly have not done any left bundle area pacing in this population. Very often the left bundle area is very difficult to find. Maybe the audience here have experience in this population, which I'm very keen to hear. So in conclusion, Chairman, ladies and gentlemen, an acquired heart disease patient without congenital heart disease, it has come a long way in terms of conduction system pacing. We become a generally recognized this is more physiologic. There's early data showing the benefit of this over and above the left bundle, so left ventricular pacing and the CRT scheme. There are a number of randomized controlled trials underway to look at different patient population, including heart failure, without heart failure, and atrial fibrillation in heart failure mentioned in the earlier talk. In terms of patient with congenital heart disease, we are at the very early part of the journey. There's no doubt we do also recognize the single ventricular pacing without conduction system pacing is detrimental. There are many anatomical considerations in this population, making this procedure can be rather challenging, and very often we have to modify our tools to suit the need. Whether there is acute change in hemodynamic and long-term clinical outcome to the benefit of our patient is yet to be seen, and forward to working with the rest of the community to look into this area further in the years to come.